One of the questions that you may ask yourself before starting this course is why would you learn focused cardiac ultrasound? Indeed, we are experts. You may have 24 hours referral to expert cardiologists and sonographers to help you, but there are still some advantages in performing yourself your examinations and asking for confirmation by specialists. So why is ultrasound so popular in the ICU and becoming so popular in medicine in general? First, you can perform it at the bedside. You don't need to move the patients. You don't need to take them anywhere or to mobilize any other resources. It's non-invasive, so the patients like it, and it's pretty easy to do. It's also fast. In a few minutes, you will be able to have some cross informations which may help you to triage or to direct the management of the patients. You will have the results real time because the same person or the same physician who does the examination will also interpret them. And you will be able to integrate the results directly in patient care without having to wait for another advice or another person helping you and being available. So you will be doing the examination yourself, have the result in real time, and integrate that directly to manage the patients. And it will be useful for the diagnosis of diseases, the assessment of function or volume status, and the monitoring of the patients before and after a new treatment is started. Recently, the use of echocardiography in a general hospital in the United Kingdom showed that there was a change in the clinical management of 51% of patients in a critical care unit. It has also been demonstrated as a valuable tool in the ICU to improve outcome. Unfortunately, we don't have any hard studies to show that, and we're still lacking hard points for the utility of bedside focused ultrasound, but it's getting increasingly used. So why would you learn ultrasound yourself and not refer to experts? Well, the first thing that you will have real-time performance and results. You can repeat it as often as you want. You just have to leave the machine next to the patient and come to take a look as you're doing your clinical examination or evaluation. It's also very easy access. You can have it 24/7 and don't have to wait for the echo lab to open or for the attending to come. So you may be free to repeat it as much as you want and to monitor your patients with ultrasound as well as with clinical examination or other diagnosis or monitoring modalities. But be careful, it has different objectives and gives you different informations than formal examinations. It is goal-directed, focused to answer specific questions in specific cases. So you are not going to do a comprehensive examination. It's not going to be as precise as a formal examination. So it will give you different informations such as, is the left ventricle pumping? If yes, I may not need to give inotropes, but if there is a significant left ventricular dysfunction, then inotropes such as dobutamine or epinephrine may be a good choice to improve the hemodynamic status of the patients. The most important is to understand that focused cardiac ultrasound does not replace comprehensive examinations. It does not replace other imaging modalities, but it's important to collaborate with the other specialties to know the extent of what you can and cannot do safely for the good of your patients. Echo is deemed to be a difficult skill to learn, and this is true. A comprehensive examination requires a lot of time and a lot of experience. The American Society of Echocardiography has issued some recommendations for training which are not compatible with a 1 or 2 years critical care fellowship or a postgraduate training. These recommendations are for level 1 would be 3 months of exclusive training in echocardiography, with a minimum number of examinations performed of 75 and a minimum number of examinations interpreted of 150. And this is not compatible with a non-cardiology training. Besides, this certification is not available to non-cardiologists. So it's different. Also, a comprehensive echocardiography will integrate multiple complex imaging modalities such as advanced Doppler, 3D examination, strain quantification, which are way beyond the scope of focused cardiac ultrasound. So here's a few examples of everything that you could do with a comprehensive examination, which will have at least 40 to 50 different images and recordings, and we'll do an analysis very comprehensive of all the cardiac structures, including systolic, diastolic function, and estimation of all the valves. So this can be very long, very time consuming, but will give you very comprehensive informations which may be useful for the treatment of the patients. However, most decisions are based on simple informations, such as, is the left ventricular function normal? Is the right ventricle dilated? Is there pericardial effusion? Or what is the volume status of my patient? Also, although the learning curve is very long for a comprehensive evaluation of the patients, the initial learning curve is very steep. And at the very beginning, within 20, 30 or 40 examinations, you will feel more comfortable in obtaining images in most of the patients. These will not be perfect images. You will learn only a few of the transthoracic views and windows, but they may be helpful for you to take care of your patients. And also semi-quantitative informations are sufficient to get diagnosis and treatment in most cases. Most of the time, when you take care of critically ill patients, you don't need to know as much if the ejection fraction is 42 or 46%, but you need to know if it's pumping adequately. You can decide if you need to give inotropes or if you do not. So here's a few examples. In the middle is an apical 4-chamber view with a normal heart. And you can see that this heart is pumping adequately on the left ventricular side and the right ventricular side. We don't see any fluid around the heart neither. And I'm pretty sure that even without any training, you will be able to see that this image on the top left of the screen shows a heart which is not pumping. The left ventricle is barely moving and is not pumping adequately the blood out of the left ventricle. So this is a severe left ventricular systolic dysfunction. If you take a look at the right ventricle, you can also see that it's not really pumping. It's not really contracting, and its function is not as good. With a closer look, you will see that line in the right ventricle, which is probably an implantable cardiac defibrillator. If we go to the image on the right hand side of the screen, you can see that the left ventricle seems to be pumping adequately, but the right ventricle is very dilated. It's twice as big as the left ventricle, and the right ventricle is not pumping. So here we have a severe right ventricular dilation and enlargement. On the bottom left of the screen, this is another example. And you see that the left ventricle is pumping adequately pretty quickly. The right ventricle is contracting adequately too, but you see a large black stripe around the heart, which is a significant pericardial effusion. So this patient was in tamponade. And another indice that you can look at here on the bottom right of the screen is the inferior vena cava. Here is the liver, and here we can barely see the inferior vena cava, which is completely collapsed and not moving, which may suggest that the patient is dehydrated, but with many limitations that we'll review later. So you can see that within one view, and even without training, it is pretty obvious that you can see if there is a significant disease, such as significant left ventricular dysfunction, severe right ventricular dysfunction and enlargement, significant pericardial effusion, or decreased size of the inferior vena cava. The second step would be to determine the curriculum that you need to learn to be proficient in focused cardiac ultrasound. It will depend on the scope of the ultrasound program. Will you focus on transthoracic and or transesophageal echocardiography, and what should be the curriculum? So the scope of the ultrasound program will depend on the interest and resources. In this course we will focus about cardiac ultrasound, but emergency physicians and many other specialties find on the FAST, which is the assessment of intraperitoneal fluid, or the lung ultrasound, detection of DVT or abdominal ultrasound may be very useful. So this course focuses about cardiac ultrasound, but there are other applications of ultrasound which may be useful in your area of specialty. Then you may want to know if you're going to focus about basic two-dimensional estimation versus advanced echo, which will require much more time, training, and efforts than the basic echocardiography. And then will you focus on transthoracic or transesophageal echocardiography? Transthoracic is non-invasive, it's easier to understand, and it's very easy to repeat in some patients. The feasibility of transthoracic echocardiography is pretty good in critically ill patients. In one study that we did in the ICU here, there were 180 examinations from August to September 2011 in Stanford Medical ICU, and we could estimate left ventricular function in 91% of the patients, right ventricular function in 90% of the patients, inferior vena cava in 85% of the patients, and the presence of pericardial effusion in 93% of the patients. Some patients may not have any transthoracic windows, such as after cardiac surgery, in the case of extensive chest burns, and in these cases you may need to refer to transesophageal echocardiography. The curriculum on which we will focus in this course is issued from the consensus statement from the American Society of Echocardiography and the American College of Emergency Physicians for the performance of focused cardiac ultrasound. We will look for the assessment for the presence of pericardial effusion, of the global cardiac systolic function, of the identification of marked right and left ventricular enlargement, the intravascular volume assessment. In this consensus statement, it was also mentioned the guidance of pericardiocentesis and the confirmation of transvenous pacing wire placement, but we will not cover these topics as they are not as frequent and may have different implications than the topics mentioned previously.